Good afternoon, everyone, and welcome to our final EITP webinar Wednesday for the season. I want to welcome you all and hope you're enjoying the great weather we're having because it is finally spring is here, I believe. Just want to kind of remind everyone that, no, never mind, hang on. I'm reading something else, sorry. Our presenter for today, I want to introduce Dr. Kaitlyn Olson. Dr. Olson is a board-certified pediatrician and fellow in developmental behavioral pediatrics at the University of Chicago. She has an interest in early childhood development and the chronic care of medically and psychosocially complex children. I'm sure Dr. Olson will share a little bit more about herself when she gets the mic. Your moderators for today are myself, Maria Maddox, and Alyssa Jones, research specialist with the EI training program, will be helping facilitate any questions folks have, any polls that we do, things like that. Just with every other webinar, I want to remind everybody that you should have gotten a personal email. You will get a personal email that is from the EI training program with a survey that you will need to complete after the webinar is over in order to get your certificate of attendance. We do ask that you complete that as soon as you get that, and you should have your certificate within the next 24 hours. Since we are participating in a webinar, we can't see each other, but we can certainly talk to each other. So there are a couple ways that we do this to participate and share with each other. The first is using the chat function, which is the bottom box at the bottom on the left-hand side of your screen. This is the box that you will use to ask any questions that you might have, share any strategies, make comments about something that anyone has said. Basically, this is how you talk to us. So I would like to make sure that everyone uses the chat box so that we can get really good participation back and forth with each other. You also can enlarge that chat box if you want to see more of what's being typed, and you can actually detach it and move it around on your screen if you so choose. Another couple of ways that you might show your interaction is through using the boxes that are underneath your name. There are 4 boxes there. The first one is an emoticon that you can use to put in an emotion. We don't really use the second box. The third box is there might be questions that the presenter might ask you to raise your hand to indicate an affirmative response. This would be the third box that you use. The last box is our polling function box that we use to gather information from everyone. And we usually start with a poll to kind of find out who is on our webinar today. So if you will open up that 4th box and indicate whether you are a parent or a caregiver, an early interventionist, representative of CFC staff, an administrator, or an other. And if you are an other, let us know what type of other you are. We'll give folks a few minutes or a few seconds to respond. Let's see. And I do ask that everyone participate. This is a really good way for us to find out who is on the webinar and so that we can make sure that we are addressing everyone's needs. So let's see. All right, let's see what our results are. Looks like we have a strong percentage of early interventionists with a parent or 2. I actually didn't mark mine. And some other representatives here as well. Thanks, Colette, for letting us know what type of early interventionist you are. But along that vein, we are going to do a second poll to find out for our presenter what type of early interventionists are in the room. So if you would open up your poll function again and let us know whether you're a PT, OT, SLP, DT, or again, an other. So we can find out specifically what types of providers are in our room. Give folks a few seconds to do that. Marilee, DTH, thank you very much. SLP, thank you, Pam. All right, let's see what our results are here. So, Kaitlyn, it looks like we've got a large number of developmental therapists and speech-language pathologists, and it looks like a lone OT at the moment. Folks are still logging in. So, with that said, I'm going to turn it over to Dr. Olson, Kaitlyn, and she will give us her presentation and share lots of information about international adoption. Kaitlyn?
Thank you so much, Maria. I am very excited to be with you guys today and be talking about international adoption. Growing up, I had a few friends who had been internationally adopted, and then I worked a lot with this population and similar populations through some international work that I have done. I think that children who have been adopted from international locations are a unique population, and they have very specific medical and psychological needs that are challenging to address, but they're very important to address. And I think as parents and pediatricians and early intervention providers, we're in a really unique position to make a big difference in the life of these children. And rarely in medicine do you see children make such rapid and drastic improvements in their health and development as you do in the children who have been internationally adopted. So I'm excited to take this time and share with you my knowledge today. So what we're going to talk about over the next hour is, first, I'll go through some background and talk about the history of international adoption, as well as some information on rates and statistics regarding international adoption today. After that, we'll go briefly into what the adoption process is like from both the parent and the child experience. Then we'll talk about what it's like for the actual transition to home for both the parent and the child. And then most of the time spent today, I'll talk about medical comorbidities and developmental challenges for children who have been internationally adopted. And through this process, we're going to go through a lot of information, but I really want to make this session as interactive as possible. So please feel free to write questions or comments in the comments box at the bottom throughout the course of the webinar today. And we'll start off actually with a question. So in your work for early intervention or as a parent or caregiver, have you personally cared for a child who has been internationally adopted? And just take this moment to answer yes or no.
Right, go to that fourth box under your polling function and indicate whether it's a yes or a no. We'll give folks a few seconds to respond. We do really request that each of you use that polling function to respond. That's how we can capture the data. So if you're typing it in, can you go to that fourth box under the polling, under your name, which is the polling function. All right. Okay, let's see what our
Great. Well, I'm really glad that you guys filled this out. So it looks like quite a few of you have had experience caring for someone who's been internationally adopted, and about 30% maybe haven't. But I think that it's common enough that you will probably see it during your career, and I'm excited that you're here to learn a little bit about it. So let's get started by talking about the history. So adoption itself began a very long time ago. In fact, the first recorded legal adoption in the United States occurred in 1693 in the colonies when the governor of Massachusetts, Sir William Phipps, he's pictured here on the slide, adopted his son. So way back before 1700 is when adoption first legally started in the U.S. And then in 1729, the first U.S. orphanage was created in the state of Mississippi. In 1851, Massachusetts passed something called the Adoption of Children Act, and this is considered to be the first modern adoption law. And this is a big turning point in the adoption movement because it stated that adoption was a social and legal process and that the whole purpose of adoption was to improve the welfare of a child as opposed to meeting the desires of an adult. And so all of this time passes, but international adoption didn't really become popular until about World War II. At this time, there were many children whose parents had been killed in the war, and also many children who had been displaced from their families. There were also many U.S. soldiers who were sent abroad during World War II and later wars who ended up fathering children, and these children were mixed race and discriminated against. So this left a lot of children without families or homes. And because of this, several religious organizations in the United States started publishing stories about the terrible plight of these children, and they appealed to humanitarian interests back in the United States, and that's how international adoption really began. Pictured here on this slide is the Doss family, and they are a family who further publicized international adoption. Helen and Carl Doss adopted 12 children internationally, and they published their story in the Reader's Digest. And that really is when the movement became very popular. And then after the Korean War in the 1950s, international adoption really started to peak. And despite this growing interest in international adoption and the large volumes of children that started to be internationally adopted after World War II and after the Korean War, there's actually been a reversal in the trend recently. So as recently as the year 2000, there were almost 20,000 international adoptions in the United States. But as you can see from the graph, these numbers have significantly decreased. There are still a significant number of children who are internationally adopted into the United States every year, however. And really, a lot of this decline has been due to international laws and new conventions that are striving to keep children in their country to preserve their children's heritage. So these international laws and treaties really refer to the Hague Convention, which was in 1993. And the purpose of that was to protect children by preventing exploitation and trafficking in the name of international adoption. And that law really started this movement of trying to keep children in their local countries. Despite this reversal in trends, there's still a lot of children being adopted today and children who are adopted from international locations. So in general, in the U.S., 1 in 40 children are adopted. In terms of international adoption, in 2014, 6,441 children were adopted into the United States from another country. And in Illinois specifically, in 2014, 269 children were adopted into Illinois from other countries. And I'm sorry we only have 2014 data. They usually come out with the yearly data in about March. So the 2015 data should be coming very soon. So the next question is, we know that there's a significant number of children in Illinois who have been adopted from abroad, but where do they come from? And this has significantly changed over time. So a long time ago, there were very high numbers of children being adopted from Korea and from El Salvador. However, neither of these countries is the current source of the highest number of internationally adopted children. In fact, in 2014, China was by far the country from where most internationally adopted children originated. In fact, approximately 1/3 of internationally adopted children were born in China. Rounding out the other countries from where children tend to be internationally adopted today are China, followed by Ethiopia, Ukraine, Haiti, South Korea, Congo, and Uganda. And so we know that there is a big diversity in where these children come from. I mean, if you look at the map, some are from South America, some are from Asia, Africa, and Eastern Europe. And all of these children have very unique backgrounds and experiences prior to coming to the United States and coming to live with their adopting families. So we'll talk about the process a little bit. I just kind of want to see how familiar are you all with the international adoption process. Are you very familiar with the process? Sort of familiar, you kind of understand the basic steps involved. C, you know the process is complicated, but that's about it. Or do you really have no idea at all about what the process is like?
All right, we'll give folks a few seconds here to use their polling function, that fourth box under your name. It should have a letter in it, and see what kind of responses that we get. Let's see. Give folks a few more seconds to respond. All right, here's our results. So it looks like folks really know it's kind of a complicated process, and some are somewhat familiar with it. So, Kaitlyn?
Great. That's kind of what I expected. The process is very complicated. So the process to adopt any child, either from abroad or domestically in the United States, is very long and complicated. And I'm going to give you a very basic overview of the process, with the caveat that I have just learned about the process through experience in working and have never been through this process as a parent. But what I've heard from parents is that the process can be very overwhelming, and it's also very confusing. Usually the first step is that families identify an adoption agency. They have to go through extensive background checks, lots of interviews, and home visits. They fill out lots and lots of paperwork. The families usually pay a significant amount of money. Typically it's tens of thousands of dollars. And the families have to wait a very long time, anywhere from a few months up until several years, just to meet their child. So I think understanding that it's very complicated and lengthy and expensive process is important for one main reason, which is that we understand that children who come into adopted families are very much desired, and their families have had a lot of time to build up their expectations and their hopes and dreams about the incorporation of their child into their family, which is a wonderful place of preparation and a great home for the child. But the child's experiences tend to be very different from the parents in terms of the preparation before adoption. So although some children living internationally are adopted from foster homes, many are living in institutions or orphanages at the time of adoption. Foster homes tend to be a little bit better, but institutions are often have, a paucity of developmental stimulation. They have limited playthings and toys. The children often have limited food. There's lots of infections, parasitic infections specifically. And the children typically have frequently changing caregivers, and the caregivers have many children to take care of, so they can be overwhelmed. So these aren't, as you can imagine, wonderful locations to promote early child development. And children tend to be in these institutions for a long time. So the average age at which a child is adopted internationally is about 22 months. And this means that these children have had, a long period and a very formative period in their life that's often been filled with neglect and inconsistent caregiving and a lack of appropriate developmental stimulation. So as you can imagine, these children have already started to have developmental delays by the time they get here, and we'll talk more about that a little bit later in the talk. And so while the family has been preparing for the child and eagerly awaiting the child, the children tend to be in situations where they're environmentally deprived, or at least developmentally deprived. And then one day, a family comes over to adopt them, and children tend to have very little preparation for this. And they're also very young, so it's not very easy for any child to process any type of preparation that they are given. So these children essentially go from a world of deprivation and neglect and being around strangers to meeting these new people who are complete strangers to them, who often smell different, look different, sound different, eat different food, And these new parents are, obviously loving strangers, but they also are people who have expectations of the child. Instead of, ignoring the child or just trying to get whatever around the institution needs to get done, the parents desperately want the child to play with them and interact with them. And the child really has no idea how to do this many times, and the whole process can be very overwhelming for children. And I really wanted to go into this because this can really make the transition home very rough for all members of the family. Most times, families have very little time to get to know or meet the child prior to adoption. In one extreme example of South Korea, the children tend to be uprooted and flown to the U.S. before the family even meets them. So the family doesn't know the child doesn't know the family. The child has a huge change in environment and expectations, which they have very little preparation for. And this is a big setup for a lot of family challenges and transition challenges in the home. So at this time, I just wanted to pause and take a break and see if you had any questions for me based on the background that we just went into.
Okay, I've been kind of monitoring the chat box. I'm not seeing any questions in there, but I did have a private question that was asked to me of how are children, how do families learn about the children in these countries? And do they get have a choice, or how are they selected? That's the best way I can respond to or reply to that or indicate that question. Sorry.
That's a great question, and it really depends on the situation and the agency for the families working with. It also depends on the country from which a child is adopted. Oftentimes they can get some type of medical records, birth records, and history from people in the institutions. Sometimes families can even get a video, which can actually be very helpful in kind of figuring out their cognitive levels and how malnourished they are and things like that. But it's really very variable. There are some countries, I believe Kazakhstan is one of them, where the families can actually go for a long period and get to know the child and meet them, but that's pretty rare. Usually it's just information that is sent to the family. Most of it's paper. Occasionally they see videos, and then they can decide whether or not they, based on the information have been given, want to accept the child or wait for another child. Another really important thing to note, though, is oftentimes medical records are inaccurate or not necessarily complete, so it can be very difficult to kind of use them and counsel families appropriately.
I think that kind of references the question that Amy has asked about, are parents made aware of these challenges by the agencies that they're working with?
Well, most of the parents who are willing and able to go through this process tend to be better off financially and more well educated. So first, in my experience, they tend to be, doing a lot of research on their own. But the agencies also provide them with a lot of information. I'm not sure exactly what. It really depends on the agency. Like the agency handles all the legal problems and they help give the family paperwork, but they're also the people who are giving the papers to the family about the child and presumably doing some level of counseling about what that means. It just depends on the agency.
Okay, I think that's all the questions we have at this point in time, so we can continue on with the presentation. Thanks.
Great. Well, then we will really get into the heart of our talk now, and first talk about medical comorbidities. So just to kind of get a sense, traveling internationally definitely has its risks, and these children that are coming from abroad often have many medical challenges. So I just wanted to see, have any of you guys gotten sick while traveling internationally? Yes, horribly ill, B, mildly ill, C, never ill, or D, haven't traveled abroad.
All right, so use that poll function, that fourth box under your name, and let's see what kind of responses that we get. It takes a few seconds here to respond. Okay, let's see what our results are. So, looks like the majority of folks really haven't gotten ill, but there's a mix of answers. So I'll let you address that, Kaitlyn.
Well, that is really great that most of you have not been ill when traveling abroad. I was actually a little surprised by the results, but I'm happy to hear it. That's good. But we'll talk about the medical comorbidities experienced by these children who tend to be adopted internationally. So medical challenges and adverse exposures for these children occur even before they're born. So many women have poor access to prenatal care or no prenatal care. There are some regions where there is high rates of drug and alcohol abuse. And this is actually rates of drug and alcohol abuse. Obviously, drug and alcohol abuse can happen anywhere, but some regions tend to be notoriously worse for this than others. So children adopted from Eastern Europe, for example, tend to have a higher risk of being exposed to drugs or alcohol in utero than children from some other countries. There also tends to be high burdens of maternal infectious diseases, as well as underdiagnosed maternal chronic illness. And all of these factors can affect the baby and have a long-lasting developmental effect on the child, even though they occur before the child is born. And then after birth, many children who are adopted from international areas tend to live in institutions, and they almost all live in conditions of poverty and oftentimes neglect. So with this comes increased risk of malnutrition and associated nutritional deficiencies. There's a high risk of stunting, so worsening growth, high rates of infectious diseases, including parasites, very poor dentition, and also, for unclear reasons, there's a high incidence of vision and hearing impairment among children who have been adopted from international locations. And it's probably due to a combination of factors. It's probably due to, maternal infectious diseases and maternal health problems, as well as early infectious diseases in children. But the complete picture of why they tend to have higher vision and hearing impairments is not clear. But due to all of these challenges and medical problems, a very high percentage of internationally adopted children are classified as having special health care needs, or Children with Special Health Care Needs is the acronym, CSHCN. So whereas 19% of the U.S. general population, the U.S. general pediatric population, is classified as a child with a special health care need, almost 40% of children who have been internationally adopted classify as having a special health care need. So the rates are pretty much double in this population compared to the general U.S. population. And of course, as we all know, medical comorbidities, especially things like vision and hearing impairment, really impact development. And so I really want to spend the bulk of our time talking about developmental considerations and things you guys should be aware of and can help with in taking care of these children who have been adopted from international locations. So the first thing that I think is important for early intervention providers and families and other early child providers to know is that upon arrival in the U.S., almost half, or approximately half of children who have been adopted from international locations will meet criteria for global developmental delay. But our screening tools aren't really validated for this population. So for example, most of our screening tools involve a language that a child doesn't understand. They use things like toys or beads with a string or puzzles when these children have not necessarily ever been exposed to these materials. So the screening tools aren't that great, but that doesn't mean that we shouldn't use them. I still think we should use them, and they're the best tools that we have. But as providers, you should be aware of the limitations of this early assessment. And also, as you're assessing children, kind of keep in mind that most of these children who've been adopted internationally will have some degree of growth impairment. Typically, weight is impaired before length, and head circumference is the last measurement to be affected by malnutrition and other problems. But children's developmental level, when they arrive in the United States, tends to be on par with their growth. So that's just one thing you can keep in the back of your mind. And another really important thing to remember and to counsel families about is that these early developmental assessments and their scores do not necessarily predict later functioning. So what we do know is that there are very high rates of developmental delay early on. As I said before, about 50% will meet criteria for global developmental delay. And we're going to talk specifically about developmental domains and challenges in those domains in just a few minutes. But overall, even though there's high rates of delay when children are initially adopted, children end up doing very well in the long term. So studies estimate that the overall cognitive level of a child who is internationally adopted will approximately match the average cognitive level of age-matched peers from their native country. So these children are going to do better cognitively than children who have been in foster care institutionalized in their countries. They're going to do what the typical well-cared-for child in their country can do cognitively. Of course, there's many factors that come into play when determining the eventual outcome for each child. So, prenatal substance use, genetic problems, were the children institutionalized or in foster care, and what age were they adopted into the U.S. all kind of play into this and help determine how each individual child will do. But the overall take that I wanted to just emphasize is that I'm about to spend a lot of time talking about all these developmental challenges that children face, but they face them right away when they come to the U.S., and then they overall tend to catch up and do really well. Before we get into the developmental domains, I just wanted to take one other moment to see if there are any questions.
Right. It looks like Desiree had mentioned kind of from the previous discussion about the things that parents have to prepare for, mentioned that parents do often are required to take a specific number of hours of training. Do you want to talk to any of that, Kaitlyn?
Hang on 1 second, I'm just reading the question.
Okay.
Yeah, so it really depends on, agency requirements and country requirements, like you were saying. And I don't have any of the details specifically on what each country requires, but a lot of countries now are requiring specific number of hours of education, parental education before adoption.
Also, there's a question about, do you have any strategies for providers when they go to do assessments and evaluations on children who are adopted internationally? Any additional things that they might do while they're doing those assessments or evaluations?
Well, I'm going to get into in a minute a little bit of information about challenges in specific developmental domains, but I think that the most important thing I can impart to you when doing the initial or an early evaluation is to, first of all, use supportive adoption language to help support the family through the process. And I'm going to get to a slide in a little bit that talks about things that are words that are good to use and phrases that you should avoid. And the other thing is, I think that you just need to be aware of the challenges and the experiences of the child. And I'm going to talk about, what are common in terms of sleep challenges and attachment challenges and language challenges all in a little bit. I don't think that you need to use that obviously to change your scores. You still need to do the developmental assessment with the instrument that, has been determined to be appropriate by EI and that you feel comfortable doing. But I think it's important to, just keep in context and keep in mind the fact that, these screening tools aren't necessarily great for this population. And I think the families need a lot of encouragement too, because you're going to be doing a lot of activities with the child, and the child probably isn't going to do that well on them initially. And I think that, for a family who's waited a really long time to have a very desired child and to see, and then they come home and they have a lot of problems and they're doing bad on the screen, that can be really hard for families. And I think your role as the early intervention provider is to, use the tools that you have and do the accurate screen, but also be supportive and also be knowledgeable of the challenges that we often see with these children, which I'll talk about in a couple minutes.
All right, and Susan has a comment and a question, and not really sure if this is where you're going later as well, but again, talking about the tools that are normed on U.S. children, and if you have any recommendations for how quickly children and families should be referred upon their arrival to the U.S., since you said approximately 50% are going to show approximately a 50% delay.
I think that's a really great question, and there's no, evidence-based guideline about it. I think that, in my opinion, a child needs to see a pediatrician right away when they arrive in the U.S. because there are certain things that need to be done, such as vision and hearing screens, parasite screens, lead, anemia, all of those kinds of things. And it should be someone who is familiar with taking care of children who have been internationally adopted. And sometimes that's a general pediatrician, sometimes that's a developmental pediatrician, or probably a neurologist. It's also very important that the families get immediately linked into early intervention or, the school district if the child is a little bit older. And then in terms of when do they have their first complete developmental evaluation, it's sort of up to the family. I think if the child is hooked into early intervention and developmental support services, and if the family has a good pediatrician who's knowledgeable about the health problems, is taking care of all of those, and who is supporting their development, it's probably fine for the child to wait a couple of months before they get a full developmental evaluation. But oftentimes the general pediatricians aren't necessarily comfortable with this population. So it really depends on the family and the pediatrician and the fact that the child is linked into the services that they need.
All right. I think that that's all the questions we have at this point in time, so we can continue on. Thank you.
Great. Well, then I have a question for you, and we're about to talk about all the different developmental domains. But specifically, I just wanted to get your opinion, before we go into it. What do you think, in terms of developmental domains, that internationally adopted children usually catch up first? If you know, or if you had to take a guess, would you say expressive and receptive language, gross motor skills, fine motor skills, social emotional development, or cognition?
Okay, so again, use that chat box, the polling function, that fourth box under your name, and choose from A to E. Let's see what kind of responses that we get. Give folks a few more seconds to respond. I'm looking at the letters on the side. Looks pretty one-sided here. So let's see what our results are. Majority of folks say gross motor. Is that true?
All right, you guys did great. That is true. So children tend to be behind in many, if not all, domains when they're adopted internationally, but the gross motor skills catch up first. And the visual motor or the fine motor skills catch up next. And the last things to catch up are speech and language and cognitive skills. And social emotional development also tends to catch up much, much later. So we'll talk about each of these individually. So first, speech and language. Often when children are being adopted from internationally, as we talked about earlier, they're about age 22 months. So they usually have some knowledge of their native language when they come to the United States. As they're transitioning into their new homes, many times they are not exposed to that native language at all anymore, and they're purely exposed to English. So it is not uncommon for children to completely lose language as they are transitioning and gaining another language. So there might be a brief period of time when they have no language at all. And I think it's important for providers to know that this is not, necessarily a sign of developmental regression like we see in autism or things like Rett syndrome, but it's a part of a child's natural development given their large transition and challenges in language exposure. So you don't need to be super alarmed, although if they completely lose language and it's going on for several months, like 3 to 4 months, then that's the time to start getting alarmed by this. The biggest problem really, everybody talks about speech and language because that's the most obvious, but I think that this is a really good time to talk about attachment, because this is something that the families are kind of constantly struggle with, the child is struggling with, and you as an early intervention provider are also going to be struggling with and having to adapt to. So attachment for these children can be very difficult. As we talked about before, they have inconsistent caregivers. They may have never bonded with a caregiver. They may have had multiple people that kept changing and no real consistency. So attachment is not a natural thing for a lot of these children. And while children can have great gains in motor development and speech development and catch up in a lot of other domains, attachment tends to be one of the most challenging. So for instance, there was a review of 7 studies of children adopted from China, and this consistently showed that whereas children were catching up in gross motor, fine motor, and cognitive skills at 6 to 12 months post-adoption, at 1 year post-adoption, they still had less secure and more disorganized attachment to caregivers than would be expected. So you might not come into the family and feel this immediate bond with the child, and you might notice that the family member is not having a great bond with the child. And I think that the most important thing for you to do is, try to be consistent in your care of the child, and also to listen and be a sounding board for the family and reassure them that, this child had a difficult early developmental experience and that attachment takes time, but that doesn't mean it's not going to happen. And one other thing that you can really do to support the family is to model healthy adoption language. I specifically took this chart from Adopt Connect, but I thought it was a really good example. So, never using things like real parent, say birth parent, or never say, the child was illegitimate, they're born to unmarried parents, the child was never abandoned or rejected, more separated from parents. Just framing things in a little bit of a more positive light. And another topic that might come up is parents might ask you whether or not they should tell their child that the child is adopted and when should they do it. And it's actually very strongly encouraged that adopted children are not blinded to the fact that they've been adopted and that this topic is introduced right away. Now, of course, it doesn't need to be a major point of discussion. The family doesn't need to tell the child every day that they've been adopted. And this really, obviously refers more to younger children who have been younger at adoption too, that have not that many memories from their prior life. But the big thing is that the fact that children are adopted should not be kept a secret, because this really introduces an element of distrust in the relationship, and that's further going to cause challenges with the child attaching to its parents. Aside from attachment, sleep can be a significant challenge for newly adopted children, and their families. Of course, the most obvious challenges are the fact that the child has transitioned time zone, but they're also changing usually their bedding, changing the setting in which they sleep. Many children who are adopted from institutions have never slept in a room by themselves, so that can be quite scary. They also, are just starting to trust this new family and form a bond with them, and have just experienced a very rapid life change where everything they knew once that was familiar was immediately taken away from them. So that can be very anxiety-provoking and fear-provoking, and sleeping by themselves in a strange setting can be very scary for these children, and it can manifest as them getting out of bed frequently, being very anxious, waking up parents in the night, crying and screaming. And just like for children with other sleep problems, gradual extinction sleep training is really good for this. But unlike children who, are in their biological families and, staying in one household, addressing the sleep challenges doesn't necessarily need to happen for this population right away. I think it's most important for the child to be allowed to get used to the situation and to establish a bond with their parent before necessarily trying to curb the bad sleep habits immediately upon arrival into their new home. Beyond sleep, many children also struggle with just playing. And that's because they haven't been exposed to many toys, or if there were a few toys in the institution where they were living, the children really had to fight for them and kind of hoard them away. And in addition, they really didn't have a lot of opportunities many times to engage in interactive play. So you might give a child a toy and they just don't even know what to do with it. And they need to kind of be encouraged and taught, and also to know that, the toy's around and it's a secure thing for them. Another very challenging aspect of caring for a child who has been internationally adopted are feeding challenges. And there's many reasons for this. So one is that these children have often experienced hunger. And so this can lead to overeating and hoarding of food when they come to the United States. Usually this gets better over time. But the general school of thought is that families should make food as available as possible and show the child, this is where we keep this, you can get it at any time. If the child starts hoarding the food, actually give them a food-safe storage container to store it in as their special hoarding spot, so they're not, sticking things under the bed. Over time, the child should realize that he or she is not in a position of food scarcity and that these behaviors should get better. Some other challenges related to feeding are that many children have been exposed to a limited food repertoire. So they might not have experienced many different tastes and textures, and many children can be averse to variety. So that is not something that's necessarily, a sensory feature that's characteristic of like autism spectrum disorder, but it might just mean they've never been exposed to it. So it's hard for them to get used to that at first. In addition, it's a common practice in some institutions to feed children as quickly as possible. And that is by continuing to feed them through a bottle even as they get older, and often by cutting a large hole in the nipple of the bottle so that children can feed very quickly. Now this is very problematic because when this is how children are used to eating, they have to develop different swallowing mechanisms that focus on slowing down the food consumption to prevent choking, and they don't develop the typical muscles of mastication and learn the typical way to feed, and so that can make feeding very difficult as well. So there are psychological challenges to feeding, sensory challenges to feeding, and musculoskeletal and structural challenges, and these can all impact feeding. Do you guys have any questions before I go on to our last segment?
It looks like, oops, hang on here, I lost it. Eileen wants to know if you see an increased percentage of children who are internationally adopted showing signs of mental illness when they hit their teen or young adult years.
So there's been a lot of research on that, and it a little bit depends on how you define mental illness. And we're going to get into this a little bit later, but we do know that while children make great gains in motor skills, speech and language, and cognition, and they make great gains in behavior too, relationship building tends to be challenging. Just attachment's always a little bit harder, and as children become teenagers, the attachment piece can become hard, the identity piece can become hard, and so this can lead to, especially in the teenage years, some feelings of sadness and anxiety, and trying to work through this and process their family situation and their life situation in their own head. I have not seen any evidence that there's increased risk of schizophrenia or other things like that.
Okay. And Kathleen has a question about what would be considered a standard time for a young child, birth to 3, to make overall transition, developmental transition. What would be kind of a norm?
Well, you should, I think your question is just like, when should you start to see some gains in different areas of development? And I would say you should start to see some pretty significant gains within the first 6 months, and definitely within the first year. But usually even within the first 6 months you should see something. Did that answer your question, or were you referring to something else? Okay, great.
Yes, yep. I'm looking through here, and I'm not seeing any other questions at this point in time, so we can continue on.
Great. So the next slide I'm going to take you to is just a scenario, and I want to see what you feel about this. So let's say you are taking care of a young child who has recently been adopted from an orphanage in another country. During your visit, you notice that he frequently bangs his head, rocks, and abnormally moves his fingers. In your opinion, what is the most likely diagnosis? Is it autism, fetal alcohol syndrome, an unspecified genetic disorder, or expected behavior?
Okay, so again, use your polling function, that fourth box under your name, and indicate your choice between A, B, C, or D. Give folks a few seconds to respond. We appreciate all of you who are responding to the poll. It really gives us a good feel for the answer or how folks are answering. Appreciate that. All right, let's see what we've got here. So most folks say an unspecified genetic disorder. The predominant number of folks say that. So what is it, Kaitlyn?
Great. So yeah, it looks like most of you said D, so maybe expected behavior. And you're right about that. So basically, many children who have been adopted from international locations grow up in environments that are very deprived. And as a result, there can be a lot of development of self-stimming behavior. So these children can demonstrate, head banging, rocking, staring at their fingers, doing atypical movements. And these are not necessarily signs of autism or a terrible neurologic disorder. They should improve actually as soon as several weeks, but definitely over the course of months, these should get better. And of course, a child adopted internationally can have neurologic disorders, and they can have autism too. It's just not something that you necessarily need to jump to when you're seeing these behaviors in children who have been recently adopted because it's a common thing that we see. In addition to self-stimming behaviors and the sensory challenges with food, bathing can present a lot of sensory challenges for children who have been adopted, and this is often because in orphanages, these children are bathed by plopping them very quickly into cold water, and a very negative association is made between the child and bath time. So that's one other place where sensory challenges can be very significant. And then a very, very important thing to talk about for these children is behavior, because children who are internationally adopted often have a lot of behavior issues. They can have very significant temper tantrums. They are often aggressive initially towards others with hitting and kicking. And this really stems from growing up in an environment that was not necessarily nurturing or consistent, and also due to the stress associated with their life changes. But one thing that's really important to know is that, first of all, these behavioral challenges can be addressed in the same way that we address behavior challenges in other children. And the second thing is that these behavior challenges don't last. So they've done a lot of long-term studies of behavior outcomes in these children, and long-term behavior outcomes are not any more common than they are in the general population. Really, the biggest things that tend to last are challenges with attention and ADHD. Those tend to be more common in this population, but behavior challenges and problems with cognition and other things tend to get better. But as you can imagine, if you have been eagerly anticipating your child coming home and they have all sorts of developmental delays and behavioral challenges, the family's going to have a really hard time. So they often, simultaneously love their child but are overwhelmed, disillusioned by the developmental challenges. And they also probably have sleep deprivation due to their child's sleep challenges. So post-adoption depression, just like postpartum depression, is not uncommon, but studies show that families will rarely talk about this unless directly asked. So this is something, especially if you're going into families' homes, that you should be aware of and supportive of. And it's important to provide them with reassurance that, there are a lot of challenges now, and the attachment is hard now, and the transition home can be very rough, but these children make extraordinary catch-up. And studies show that, the children tend to do really well over time. And studies also have looked at parental mental health over time for internationally adopted children. And they show that the parents tend to be very happy and satisfied with their decision to adopt and very, have a wonderful relationship with their adopted child in the long term. So it's just really trying to be there for the family and the child and getting them through this difficult period. That's very important. So in summary, I think the biggest things I want you to take home from this lecture are that developmental delays in children who have been internationally adopted are very common. This does not make their development normal, and they still really importantly need, support from knowledgeable and loving caregivers and intervention teams. But these children develop great catch-up and have wonderful long-term outcomes. And the most important thing is to support the child's needs at the time of adoption and to support the needs of the parents as well. If you want to look up anything I've talked about, I have a list of a bunch of references for you guys. And at this time, we'll take any other questions you have.
Looks like Susan has kind of reiterated what you just said, is that, these children do have global delays, so a more global approach in working with families and specifically focusing on the parent-child relationship seems to be very important. Anything more that you would like to say to that?
Well, I think that's the key right there. It's supporting the family dynamic and, really teaching the family how to interact with their child and how to, with their child's unique needs, and helping them learn to bond with their child and be a good caretaker and teacher for their child.
I had kind of have a question about some of the sensory challenges and specifically around the bath time and water. And do you have any suggestions on strategies on how interventionists can assist families in making that a little bit more tolerable and ideally pleasurable experience for both the child and the family?
I think the best way is just kind of slow exposure and making the experience as pleasurable as possible. So, making sure the bath water is a good temperature. And, just starting with, like, not even putting the child in a bath, like either doing a sponge bath, or if they're really averse, just starting and like doing some water on one arm and trying to, use the things that the child enjoys too, like if they like this special toy, like bringing it out at that time so they have an association with that, just to like try to make it a relaxing thing and just slowly getting the child used to being around water, having water on them, eventually sitting in the bathtub.
It looks like Amy has a comment and a request for suggestions. She's recently worked with a child that transitioned, and they were already too old for early intervention, it looks like, so 39 months, and they're now 4. And so they're trying to figure out when is the best time to transition for preschool and kindergarten, and I mean all those changes all at once. How do you suggest families approach all the different things that children can be exposed to?
It's definitely fine that it's not an EI-specific question. Don't worry. It's a hard question to answer generically too, though, because it really depends on how the child is doing and like what the specific challenges are. In general, getting the child into a routine is a good thing. So, if they've been home for several months, they should be starting to understand that the family isn't going to leave them, and it's okay for the child, to go to daycare and go to preschool and go to kindergarten and get into those, get into a normal routine of daily life, and that's good for them. In terms of like figuring out where to go, it a little bit depends, on the child and just making sure they're well supported. And of course, it's probably easiest for the child if there's at least some familiar kids in their class from preschool to kindergarten, just like it is with any like other, child. And it's particularly important for these children who like, consistency and have had inconsistent attachment, but that's not always feasible. And it's, if the choice is between, keeping your child with the same children and going them to a school that you feel like doesn't, like sending them from preschool to a kindergarten that you don't feel like fits their academic and therapy needs, that's probably not the best bet.
Is there a particular medical condition that seems to be the most predominant that children who are internationally adopted may show up with, maybe not at the time of adoption, but later?
Well, the most common things, we can pick up on early on. So, some of the most common things are parasites or malnutrition and high lead levels or anemia. Those kind of things tend to be picked up on over time. The things that show up later tend to be diagnoses that are harder to make and less common. I mean, so, you might not necessarily diagnose fetal alcohol syndrome right away, that you might figure that out over time, or other genetic syndromes might get figured out over time, but that is because they tend to be less common. So, like genetic syndromes, there's like so many of them, and like it's hard, we can't screen for them per se in children, and it can be because they're more subtle, but I don't think there's any very common diagnoses amongst this population that should be being picked up on years down the road. Other infectious diseases, that one actually that comes to mind that maybe could get missed and should be screened for is syphilis and congenital syphilis. Sometimes that one gets missed and it's not uncommon and that can be diagnosed later, but if you're doing all the labs that are indicated right away, it should be picked up on when they first arrive.
Well, I thank you for those answers. I'm not seeing any other questions, so unless other folks have questions that they want to quickly type in, I think we can conclude our presentation for today. Kaitlyn, I want to thank you again for your great information and very in-depth, very helpful information for folks. And I want to remind folks that you will get that email that has your survey. Complete that survey, and you will get your certificate within 24 hours. If you have any questions or any problems, don't get your certificate, you can contact the EI training program at eitraining@illinois.edu. Kaitlyn, again, thanks again. And at this time, I think we are done. So thanks everybody for participating.
Thank you so much.